Hello, 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 hello. This is me, likely to discuss about the psychiatry. Okay, I'll go through 20 questions and then I'll take a nap. And by this way, I will try to study from nowadays. Okay, 23-year-old woman brought to the EDs due to bizarre behavior. The roommate reports that over the past few days, the patient has become increasingly paranoid. She stays up almost all night. It believes that the apartment is bugged. So this type of thing, thinking about mania. So I choose mood stabilizer, but I should read whole question. The roommate become alarmed when the patient did not go to work yesterday and start speaking in a whisper. When interviewed, the patient does not respond verbally to questions but calmly writes on a piece of paper. I have been warned not to say anything. He has some sort of whisper going on. He has some sort of auditory hallucination going on. So schizophrenia may happen. Her parents are contacted and reports as a history of depression treated with bupropion. They have never observed the behavior their daughters is exhibiting. The patient reports that the parents reports that the patient drinks alcohol socially but do not believe she uses illicit drugs. Family history is significant for bipolar disorder in a maternal uncle. Which of the following is the most appropriate next step in the management of the patient? Stem looks like bipolar. He has mania and he has a history of depression. But before jumping into that, he has new onset psychosis, delusion, possible hallucination of unclear etiology, major depressive or manic episodes with psychotic features should be considered given the history of depression and family history of the bipolar disorder. However, before making a primary psychiatric diagnosis, substance induced and other medical cause should be ruled out. So, before jumping into the psychiatric diagnosis, first of all, we have to rule out is there any history of substance induced or is there any medical causes present or not. Basic, the basic, the basic medical workup for new onset psychosis commonly include complete physical and mental examination, metabolic panel, urine toxicology screen, metabolic panel, complete blood count. The basic medical workup for new onset psychosis, complete physical and mental examination, metabolic panel, complete blood count, and urine toxicology screen. It may also include syphilis, HIV, vitamin B12, thyroid, anti-nuclear antibody, as well as neuroimaging depending on specific findings and risk factor. In a young patient with no significant medical history and normal physical examination results, obtaining a urine toxicology screen is the most appropriate next step in evaluation of screen positive for cocaine or amphetamine suggests a stimulant-induced psychosis. The parents' reports cannot be relied to rule out the illicit or prescription drug use. Urine toxicology screen for positive cocaine or amphetamine suggest a stimulant-induced psychosis. Stimulant-induced psychosis. Okay, bizarre behavior. She's affected. Failed to respond. He failed to respond if two or more antipsychotic fail to respond. Give clozapine, and we know that clozapine causes agranulocytosis or neutropenia. So treatment-resistant schizophrenia. It is associated with the risk of neutropenia, life-threatening agranulocytosis, complete absence of neutrophil have been reported in an extremely 1% of the patient treated. These rate has been reduced with regular blood monitoring. Is 47-year-old man with a long history of schizoaffective disorder. It's a long history of schizoaffective disorder in schi- schizo in schizoaffective disorder. In schizoaffective disorder is more than 2 weeks of psychotic feature but no mania or depressive episode. So multiple antipsychotic. Mr. Schizoaffective disorder comes to the clinic with his wife after a difficult course requiring several psychiatric hospitalizations, poor response to multiple antipsychotics and mood stabilizers. The patient's condition have been relatively stable for past 3 years with high doses of lithium and risperidone. Lowering the dose of risperidone results in worsening psychotic symptom. So dose was subsequently increased. The patient's wife states that psychiatric symptoms have improved with the current medication, but they are both concerned about new abnormal movement he has begun to make. So due to risperidone, he has some sort of abnormal movement. During examination, patient is repeatedly taps his foot, taps protrudes and smacks lips. The patient is treated with sequential trials of valbenazine and deutetrabenazine, but no significant improvement. Which of the following is the next best step? It's a tardive dyskinesia. The patient's movements are most consistent with tardive dyskinesia and involuntary hyperkinetic movement disorder and involuntary hyperkinetic movement disorder resulting from prolonged exposure to dopamine receptor blocking drugs. Prolonged exposure to dopamine receptor blocking drugs, including antipsychotic and metoclopramide. And tardive dyskinesia and switch to second generation quetiapine or clozapine. Treat with valbenazine and deutetrabenazine. Tardive dyskinesia due to prolonged use of antipsychotics or metoclopramide. Tardive dyskinesia due to prolonged use of antipsychotic and metoclopramide. There may be orofacial dyskinesia, tongue protrusion, lip smacking, limb dyskinesia, dystonic posture, foot tapping, chorea, trunk dyskinesia, rocking, thrusting, shoulder shaking, greater risk of first generation, greater risk with first generation. Treatment for tardive dyskinesia: discontinue, continue causative medication, discontinue causative medication, switch to second generation antipsychotic, clozapine and quetiapine, switch to clozapine or quetiapine, treat with valbenazine or deutetrabenazine. Benztropine is drug-induced Parkinsonism. Propranolol beta blockade for akathisia. Lithium can cause tremor; it does not cause involuntary movements. 9-year-old 9-year-old boy is brought to the office by his parents for evaluation of behavioral concern. His mother says that the patient never listens and gets distracted and easily hyperactive all the time. He is unable to sit still at the dinner table and constantly interrupts her when she is speaking on the phone and makes excuse for forgetting his chores. The father says his wife is overreacting, that the patient has been very active. He adds, I was the same way as a kid. I'm sure he will grow out. It's just like I did. There have been no changes in the patient's appetite or there have been no changes in the patient's appetite or sleep. Physical examination is remarkable for a scar on his right leg, multiple scabs on the right knee, which he reports are due to falling off a bike and skateboard. The remainder of the physical examination is normal. The mother asks if there any medication that can help calm him down. The mother asks if there any medication. Initiate trial of atomoxetine, initial trial of if there is ADHD. So, interview the patients separately, obtain behavioral rating scale and from the patient's teacher. This is the answer. ADHD. So my diagnosis is correct. I'm thinking about ADHD. In ADHD, stimulant methylphenidate can be given. Non-stimulant atomoxetine alpha 2. Behavioral ADHD behavioral symptom hyperactivity, impulsivity, inattention, hyperactivity, behavioral concern, inattention, hyperactivity, or impulsivity. Impulsivity diagnosis requires 6 months more than 6 inattentive and 6 hyperactivity or impulsivity symptom in 2 or more setting. In this case, there are symptoms only in the home. There are symptoms only in the home setting. There is disagreement between the parents. Diagnosis of the ADHD is based on clinical evaluation of the symptom associated with 2 or more teacher completed behavioral rating scale are important tool for obtaining collateral information about school functioning and can assist the diagnosis. Psychiatric trichotillomania. The patients in here trigger behavior recurrent hair pulling, irregular patches of hair loss with broken hair shafts and of different length. This is irregular patches of hair loss. This is irregular patches of hair loss with broken hair shafts of differing length. Irregular patches of hair loss with broken hair shafts on differing lengths. Traction alopecia is a hair loss resulting from prolonged tension on the hair, due to hair style.